Hi, today we're going to be talking about pulmonary emboli, and that's when a blood clot that forms in the leg travels to the lungs and could block the entire heart circulation. This can be very scary and dangerous with an overall mortality rate of about 15%. Even patients who survive could take months until they recover completely and get back to their normal life. Luckily today, I'm very excited to say we have new tools to fix that and get you back to health. In this video, I will be talking about pulmonary thrombectomy, a relatively new but rapidly evolving treatment option for acute pulmonary emboli, which is also called PE. And one of the benefits of being a doctor in the Silicon Valley is that I have early access to a lot of these new tools, and I'm really excited about this one. There's a lot of new stuff in the pipeline. We'll be talking about the data from the clinical trials, the rationale behind this procedure, the indications, how the procedure is performed, the different devices that are available. We're also going to be talking about risks and complications, recovery time, and the future directions of this treatment. I hope by the end of this video, we'll have a clear picture where mechanical thrombectomy stands in modern pulmonary embolism management. Again, pulmonary embolism is the blockage of the pulmonary arteries, which is usually caused by clot that prevents adequate blood flow through the lungs back to the heart. PE can be life-threatening, especially when it causes significant strain on the right side of the heart. And in the most severe cases, the heart just stops beating. The main symptom of pulmonary emboli is usually shortness of breath. And although it can start suddenly, sometimes it can be hard to know that there is something going bad until it's already bad. Many patients may not be short of breath when they're sitting down, but they may feel super tired with minimal effort, like walking inside the house or climbing a flight of stairs. Sometimes they may be doing fine when they are working the computer or watching TV, but when they start talking, they may get short of breath. Some patients can have chest pain, which may be confused with a heart attack, and that can be dangerous if we're doing the wrong treatment. In some patients, this blood clot can cause what's called an infarct of the lung. That's when a little piece of the lung dies, and the patients can develop severe pain when they take a deep breath. That may feel like a pneumonia. So how do we diagnose pulmonary emboli? It used to be a big problem to diagnose pulmonary emboli, and sometimes people had to treat even without knowing for sure that the patients had a pulmonary emboli. But today, a simple CT of the chest with contrast dye can easily diagnose pulmonary emboli. And that is how AI is making a big difference in the management of these patients. You see, in our system, when somebody comes to the ER and have a CT scan of the chest for any reason, we do have AI that will immediately notify a team of physicians that will immediately be available to take a look at these images and take care of this patient. And I can say the communication nowadays is seamless, thanks AI. That same CT or an echocardiogram is even better, can also diagnose if your heart is suffering from the effects of the blood clots. And we call this right ventricular strain, and that's something to keep in mind. Because a large blood clot can block the blood flow through the lungs, the heart will have to work extra hard to pass through this blockage. And that's when people get in trouble, because the blood pressure can drop and they can get very sick very fast. And that's why sometimes a pulmonary emboli can be confused with a heart attack, because the same enzymes that get elevated when you have an infarct of your heart can also be elevated with pulmonary emboli. And in the setting of chest pain, that can be confusing. Of course, the EKG can be slightly different, but things can often get mixed up. That's why it's important for the ER physicians to have a high level of suspicion of these events. So pulmonary emboli, or PE, is not only life-threatening, but the heart can take a while to recover, and sometimes the heart can have permanent damage. Also, in some patients, these clots can stay permanently in the pulmonary artery, and this can cause a very serious long-term condition called CTEPH, which is chronic thromboembolic pulmonary hypertension. And sometimes this can be reversible and could even require a heart-lung transplant, which is a very serious surgery, as you know. Thankfully, this is rare overall. Traditionally, pulmonary emboli is treated with anticoagulation, which is also known as blood thinners. And some examples of those are Lovenox, Eliquis, Xarelto, and Coumadin. Thankfully, we don't use Coumadin that often because it's much harder to manage. The new ones are a lot easier. In the past, only extreme cases were treated with powerful clot busters, which in medical terms is called thrombolysis or surgical embolectomy which is when they crack your chest and remove the clots, which has a huge mortality and recovery time. Also, the patients that would undergo these treatments would have a very high mortality rate. Specifically, the clot busters or systemic thrombolysis, or also called TPA or alteplase, carries a notable risk of major bleeding, which is also a contraindication in patients who had a recent surgery or a hemorrhagic stroke or any other factor that increases their risk of bleeding. This is where catheter interventions such as mechanical thrombectomy have begun to fill an important gap. Recent clinical trials, including the FLARE trial or EXTRACT-PE trial, demonstrated that mechanical thrombectomy is not even very effective in removing the clot and getting the heart back into shape and getting patients discharged sooner, but also it is very safe with a very minimal complication risk. Long-term data is not yet available, but there's a trial on the way called the PE-TRACT study that's going to look at these patients comparing mechanical thrombectomy with just anticoagulations for up to a year. And I'm very confident that will show that the patients that get mechanical thrombectomy get back to their normal lives a lot faster, including like exercising and long-distance biking and things like that. What are the indications for catheter-based thrombectomy or mechanical thrombectomy? So we do this in patients that have what's called a massive PE. That's when the blood pressure is getting low, or patients that have a submassive PE, which they have a large PE, and also the CT scan or the echocardiogram shows that the heart's having a difficult time beating. And sometimes they can have elevated cardiac enzymes, which are called troponins, that are signaling that the heart is having a difficult time. Pulmonary thrombectomy is typically performed by interventional radiologists or experienced interventional cardiologists in a cath lab or catheterization laboratory. And I'm going to describe how the procedure is done to you. So in good hands should be about a 30 to 45 minute procedure. And what we do is we get access in the groin, usually the right groin, and we insert a catheter. It's usually a relatively large bore catheter, but the vein is a very large organ and it's usually not a problem. We then advance very carefully through the inferior vena cava, through the heart, and get into the pulmonary circulation. And then we take some pictures, we inject some dye to see where these clots are. We have a pretty good idea just based on the CT scan. Now we measure the pulmonary pressure to see how much is impacting your system. And through this catheter, we're able to essentially suck the clots out. And what we see in practice is when we remove these clots, almost immediately the patients get better. Like their oxygen levels get better. You can see that the heart is beating a lot easier. The pressures also improve, and the pulmonary pressures drop dramatically. We then take an angiogram, which is another picture showing that we remove the clots. We don't need to remove all the clots, but essentially we need to remove the bigger ones to improve the circulation. And obviously we try to remove as much as we can. We then usually use a closure device to make sure you don't have bleeding in the groin. It's normal to have some bruising in the groin side, but bleeding is actually very rare since the vein is usually a low pressure system. Like I mentioned before, the entire procedure can be done in 30 to 45 minutes, depending on the complexity and the extent of the clot burden, but we're getting pretty fast in doing these cases. But like I mentioned before, there are several devices coming in the market that offer several advantages to those. More recently, we have been exploring the Inquis Aventus thrombectomy system, which is a new generation thrombectomy system that offers multiple advantages, and we have been participating in the national clinical trial. This system offers several advantages, including clot detection, like a directional thrombectomy, so we can turn the catheter to take blood clots from different branches, for example. And it's a system that is safer and easier to use because it doesn't require use of dilators to manipulate the catheters into the pulmonary circulation. But these are doctor details and not that important from a patient perspective. You just want to be assured that we use a safe device that is effective in removing these blood clots. Although I truly believe this is a great technology that has a lot of benefits and advantages for the patients, like any procedure, it's not without potential risks and complications. The possible complications include bleeding in the groin site where we go in. There's also a risk of cardiac arrhythmias as you go through the heart to get to the pulmonary circulation, but you are monitored through the procedure, and we have all the technology to treat that if that happens, although it's not very common. Also, when you're manipulating catheters in blood vessels, there is always a risk of injury to these blood vessels, although the new technology, like I mentioned, is much safer and gentle in the blood vessel, so that's also very rare. In some cases, after the procedure, patient can have blood in the sputum, although it's also rare. In most cases, it stops on its own. The problem is if you have blood coming out in the sputum, we may need to stop the blood thinners, which becomes a problem. Finally, we also use contrast dye during the procedure, which can have some issues. In some cases of patients that are severely allergic to the dye or have high creatinine, we've done these procedures even without contrast, just by superimposing the images that we obtained with the CT scan. And like I mentioned before, the clinical trials show that the overall risk of major complications is very, very low, especially when we compare to the risk of doing systemic clot busters, or the risk of doing surgery, or even the risk of doing nothing in very sick patients. What is the recovery time? Of course, immediately after the procedure, patients are often monitored in an intensive care unit or ICU, or a step-down unit for the first 24 hours, particularly to watch for any signs of reocclusion, bleeding, or cardiac arrhythmias. But this is where thrombectomy really shines. You see, patients who have submassive pulmonary emboli may take months to recover and go back to their normal activities with anticoagulation alone. They can also be in the hospital for several days, even weeks. Now, if we successfully remove the clots, patients feel better almost right away and often go home in 1 to 2 days. They usually can go back to their normal life, even exercising in a few days. Yeah, I'm very excited because the field of mechanical thrombectomy for PE is evolving rapidly with new generation devices coming to the market all the time. And with these new generation thrombectomy devices, with newer technology, I think patients who suffer from pulmonary emboli can expect a much smoother and rapid recovery to their health. If you have more questions, feel free to contact us.